So a blessed Sunday to one and all. So here we are in the Cardio-Obstetrics Master Classes, the 8th of ours, with yet another challenging case. Today we have management of pregnancy in patients with Takayasu Arteritis. So before we move into the introduction of the moderator and the panelists, I would like our course director, Dr. Justin Polser, to say a few words about this masterclass.
Good evening, all of you. Thank you for joining in time. As always, we are also starting in time. The idea of Cardio-Obstetrics Masterclass came because we realized that we need to have a greater coordination between the cardiologists and the obstetricians, obstetric anesthetists, and all the other faculty involved in managing pregnant women with the heart disease so that the care is always better. We find that when we join together, we learn from one another and always the care improves. With that idea, the Cardio-Obstetrics Masterclass was started. And this is the 8th one. Usually we take a long time planning, but this time what happened was, as most of you are aware that we have the Cardio-Obstetrics WhatsApp group, there is a case of Takayasu Arteritis in pregnancy was shared. It was a challenge of handling that. So we thought, why not we have a discussion? Not even a week's time was there. So we just casually asked, is there somebody who's volunteering to do this case discussion or case presentation or a lecture? The Fernandez hospital team from Hyderabad, they immediately agreed to do volunteer. I sincerely thank the team Fernandez Hospital, everyone involved for having agreed to make the presentation and a short lecture on Takayasu arteritis in pregnancy. Thank you so much for agreeing to make this presentation and doing this in a very short time, not even 3 days notice. And I welcome each and every one of you here. Thank you so much. And please feel free to contribute and share your inputs on the chat screen. And I see some very senior participants. I see Anita Saxena, Madam, Titus, Sir, Dayasagar Rao, Sir. Thank you so much, sirs and ma'am, for being there. Please feel free to share your inputs because you're here. Your expertise is definitely needed for all the participants. Thank you so much. With that, I hand over to Dr. Annie to briefly introduce the presenters.
So the presenter for today is, thank you, sir. For the presenter for today is Dr. Stary Thomas. Madam is a maternal and fetal medicine specialist at the Fernandez Hospital, and moderating the session would be Dr. Malini ma'am. Madam is also the maternal and fetal medicine specialist at Fernandez Hospital. And in the panelist is Dr. Tarakeswari ma'am, senior consultant, maternal and fetal medicine specialist, Fernandez Hospital. And along with madam is Dr. Vanitha ma'am, Professor of Obstetrics and Cardiology, Obstetrics and Gynaecology, Thoothukudi Medical College. And also we have Dr. Manokanth, Obstetric Anaesthetist at Fernandez Hospital. And together with us is Dr. Dayasagar Rao, sir, Senior Cardiologist at KIMS Hospital, Hyderabad. So now we'll quickly move into the case. The session now is handed over to Dr. Malini ma'am.
Thank you, Justin, sir, for the opportunity. Thank you, Dr. Annie, for the kind introduction. I will start sharing my screen. So I thought before we go into the case for the attendee, for the benefit of the attendees, I will just briefly touch upon Takayasu arteritis, the diagnostic criteria, and how we score the disease, and then we will proceed into the case. Is my screen visible?
Yes.
Okay. So Takayasu arteritis is a granulomatous vasculitis of large and medium arteries. It was first described by Mikito Takayasu with a female to male predominance of 4 to 4.9:1. So it is more common in the Asian countries and affects women mostly in the second and third decades of life. The most common artery that is involved is the left subclavian artery, almost 53 to 90%. Other arteries are the vertebral arteries and the renal arteries. If you look at pathogenesis and clinical findings, this is a little busy slide, but I will take you through this. The pathogenesis is unclear. Many autoimmune inflammatory changes or even genetic predisposition has been postulated in the pathogenesis. So when there is active inflammation and the release of cytokines, there is increased WBC, increased CRP, and increased DSR, which we usually use to monitor the disease activity. With the release of cytokines, the patients usually feel fatigue, weight loss, low-grade fever, and arthralgias. And when the arterial elastic lamina and media are involved, there is aneurysmal dilatation, which is seen on angiography. And when the retinal arteries are involved, there is visual dysfunction. The chaotic blood flow through the involved arteries will lead to bruit, most commonly over the carotids, which we usually auscultate, and one of the criteria for diagnosis of Takayasu's. When the renal arteries are involved, there is a activation of the renin-angiotensin-aldosterone system, which leads to systemic hypertension, and involvement of the subclavian arteries, mesenteric arteries, and the peripheral limb arteries will lead to various manifestations in the form of absent pulses, limb claudication, or abdominal pain. So cardiac features include aortic regurgitation. There can be myocardial infarction or angina when the coronaries are involved, and there can be congestive heart failure as well. This is the one of angiographic classification for Takayasu arteritis, which we all follow. Type 1 is when only the branches of the aortic arch are involved. Type 2A, when the ascending aorta, arch of aorta, along with the branches are involved. 2B, when the descending thoracic aorta is also involved. Type 3 is the descending thoracic aorta as well as the abdominal aorta with or without renal arteries. Type 4 is only descending aorta with the renal arteries. Type 5 is a combination of all the above. When the coronaries and pulmonary arteries are involved, it is designated as C+ or P+ respectively. So the disease can manifest in the early inflammatory phase with the generalized non-specific symptoms of malaise, fever, night sweat, arthralgias, etc., which can present as anemia or raised DSR. And this phase may be absent in 50% of the patients. And the late chronic phase, where there is inflammatory obliterative changes in the aorta and its branches, and these are usually extensive, and bilateral involvement is seen. We also note the involvement, it can also be associated with other autoimmune diseases. So the diagnosis is based mainly on the clinical, laboratory, and imaging modalities. The clinical criteria is the modified Ishikawa criteria, which was proposed way back in 1995, where the involvement of the left mid-subclavian artery or right mid-subclavian artery and the characteristic signs and symptoms of at least 1 month duration. The symptoms are limb claudication, pulselessness or pulse difference in the limbs, fever, neck pain, that is carotidynia, transient amaurosis, blurred vision, syncope, dyspnea, or palpitations. These are the major criteria. And the minor criteria are ESR more than 20, carotid artery tenderness, hypertension, aortic regurgitation, pulmonary artery lesions, distal brachiocephalic trunk lesion, abdominal aorta, coronary artery lesions. So 2 major or 1 major plus 2 minor or 4 minor will have a high probability of Takayasu arteritis. In 2022, American College of Rheumatology and the EULAR have come out with a classification for Takayasu arteritis. The absolute requirements for diagnosis are age less than 60 years and evidence of vasculitis on imaging. And there are also additional clinical criteria and additional imaging criteria which add to the point and helps in the diagnosis of Takayasu's. The lab, coming to the lab parameters, ESR more than 20 is non-specific, as it is when it comes to pregnancy, it is usually normally increased in pregnancy as well. CRP more than 5, anemia, leukocytosis, thrombocytosis, these are usually seen. There are other various biomarkers that are investigated for the diagnosis and prognosis for Takayasu's, like vascular endothelial growth factor, interleukin-6, MMP3, but none have been actively tested or studied extensively for the prognostication of the disease. When it comes to imaging, angiography is the gold standard for diagnosis. CT angiography can also be done, and it is not a contraindication, especially in pregnancy when if the investigation warrants. Other modalities are digital subtraction angiography, Doppler ultrasound, MRI, and 18 fluorodeoxyglucose PET CT, which especially gives information about the early assessment of inflammation, and echocardiography for the assessment of aortic valve and aortic root involvement. Always remember the differential diagnosis when you're dealing with any hypertension or with the overlap of symptoms. The treatment aims at controlling of active inflammation, prevention and treatment of complications. The treatment can be medical, which involves glucocorticoid therapy, non-biologic immunosuppressive agents like azathioprine, methotrexate, MMF, and cyclophosphamide, and biological immunosuppressive agents like TNF-alpha inhibitors and tocilizumab. Surgical management includes endovascular surgery like percutaneous transluminal angioplasty and stent placement, or open surgery, which can be bypass grafting or endarterectomy. Coming to the staging of Takayasu, stage 1 is uncomplicated, and the complications being retinopathy, secondary hypertension, aortic aneurysm, and aortic regurgitation. If any one complication is present in a mild or moderate form, we call it as stage 2A, and if it is a severe form, it is stage 2B. And more than one complication will be stage 3. So with this brief introduction about the Takayasus, I now hand over to Dr. Stary.
So coming to our case discussion. So Mrs. A, 31-year-old homemaker, married for 8 years, non-consanguineous marriage. She was gravida 3 para 2 live 1. This was a spontaneous conception. This is the timeline of events. So so coming to her past medical history, in November 2015, at 24 years of age, she presented with left shoulder and arm pain, which was insidious in onset, with a history of multiple syncopal attacks and transient blurring of vision in both eyes, followed by loss of vision in the right eye. The upper limb pulses were not palpable on examination, and both lower limb pulses were equal and palpable. She had a left carotid bruit also. BP was not recordable in the upper limb. Lower limb BP was normal. Cardiovascular and respiratory system examination was normal. A carotid angiography was done, which showed a complete occlusion of the left subclavian artery and stenosis of left common carotid artery, brachiocephalic artery, and complete occlusion of the left vertebral artery, suggestive of Takayasu arteritis type 1. Echo done was normal, CRP was normal, ESR was elevated. Fundoscopy was done, which showed a central retinal artery occlusion with macular ischemia. So as per the pneumoangiography classification system, she was classified as Takayasu arteritis type 1. She was started on clopidogrel, Visalon, and statins. A carotid angiography and stenting of the left common carotid artery was performed. Post-procedure, her vision improved and she remained symptom-free for 8 months. In July 2016, she presented with chest pain, shortness of breath, and syncopal attacks, and carotid artery Doppler showed severe stenosis of the bilateral common carotid artery, left carotid stent in situ. ECG echo was normal. Angiogram showed right vertebral artery tight stenosis, and stenting was performed for the same. Immediately post-procedure, she developed left-sided weakness of limbs. She was diagnosed as cerebrovascular accident, left hemiparesis. MRI done showed an ischemic infarct in the right frontoparietal region, right cerebellum, and right occipital area. She was treated with low molecular heparin, ecospirin, clopilate, statins, Visalon, and methotrexate was started. Physiotherapy was initiated and she improved in 3 days. She continued to follow up under cardiology and rheumatology. In 2017, a CT iotogram was done, which showed circumferential thickening in the distal ascending thoracic aorta, arch of aorta, and descending thoracic aorta, which was suggestive of Takayasu arteritis type 2B. So she was regularly followed up under cardiology and rheumatology. She continued on steroids, methotrexates, statins, clopidogrel, and aspirin. No angiogram was done after 2017 as she was asymptomatic. Switched to azathioprine in the pre-pregnancy period in 2019. Coming to her obstetric history, in 2019, her first pregnancy was in 2019. It was a spontaneous conception, and she booked with us at 24 weeks of gestation. She continued on azathioprine and Visalon in pregnancy. Her ITAS score on booking was 0. Induction of labor was done at 37 weeks. Emergency section was done for non-progress of labor, and she birthed a baby girl of 2.6 kg with good Apgar scores, received postpartum thromboprophylaxis, and she continued on azathioprine and steroids postpartum. She had a second pregnancy in 2022. It was a spontaneous conception. She booked late with us at 34 weeks of gestation. She continued on azathioprine and Visalon in that pregnancy. ITAS score was on booking was 0. On examination, she revealed absent upper limb pulses. She had a history of jaundice lasting for 2 to 3 days at 36 plus 3 weeks of gestation. On investigation, it showed total bilirubin of 4 milligram per deciliter with a direct bilirubinemia of 2.7. Rest of the LFT coagulation profile, platelet and creatinine was normal. She was continued on the same medications. She had a preterm premature rupture of membranes, and she presented with a PPROM and decreased perception of fetal movements. Ultrasound examination was done, which confirmed an intrauterine fetal death, and cesarean section was done, and birthday baby girl of 2.5 kgs. Couple declined fetal autopsy. Bereavement counseling was done. LFT was postpartum thromboprophylaxis was given, and the LFT was normal 1 week postpartum. Placental histopathology was suggestive of maternal vascular malperfusion, uteroplacental insufficiency secondary to autoimmune disease. She had her third
So far, what
pregnancy.
you have done, Dr. Stary, so far you have presented the past pregnancies. This
Yes,
is the
sir.
current pregnancy you're going to present right now. Am I right? This is the latest pregnancy.
Yes, sir. This is the current pregnancy, last pregnancy.
Latest, fine. Good.
So she had a third pregnancy in 2023. She booked with us at 30 weeks, 6 days of gestation, self-referred to Fernandez for further antenatal checkups and delivery. She was continued on prednisolone and azathioprine, and echo was done, which was normal. She was asymptomatic. On examination, her BMI was 27.2 with a weight gain of 10 kgs in pregnancy, no carotidemia or bruit. Cardiovascular system and respiratory system examination was normal. Pulses were not palpable in both upper limbs. Lower limb pulses were palpable, and the BP recordings in both lower limbs were normal. Central nervous system examination showed, the motor system examination showed a left residual paresis of the left upper limb, distal more than proximal, and reduced visual acuity in the right eye. Rest of the CNS examination was normal. Per abdomen examination revealed a singleton fetus with its fundal height of 34 weeks in cephalic presentation with good fetal heart. These were her investigations in which the CRP was elevated. It was 22, and an ECG and 2D echo done was normal. Coming to the risk scoring, it showed an ITAS score of 0, an IH score of 1, and a EULAR suggestive of remission. This was the fetal monitoring done. The fetal growth scan at 32 weeks showed a large for gestational age baby at 99 centile. Coming to the diagnosis, she is gravida 3, para 2, live 1 at 30 weeks, 6 days of gestation. Takayasu Arteritis type 2B, status was left common carotid artery and right vertebral artery stenting. History of left hemiparesis, residual paresis. Previous to LSCS, previous term stillbirth, GDM on diet, hypothyroid, and large for gestational age baby.
So thanks for the case, doctor. I have some doubts here. So, for those of us, this ITAS score is Indian Takayasu Disease Activity Score. That is usually calculated based on a lot of parameters, and you can find that even in your MD Calc app in your mobile phone. So I just wanted to know, how is you say an ITAS score of 0? When you have a stroke, I think adds 0.2 plus 2 to that.
Sir, in the ITAS score, we see any change in the symptoms or new symptoms in the past 3 months.
Only 3 months. Okay.
In the past 3 months.
Okay. Right.
So that is why we gave it as a score of 0, because this was a residual palsy from her previous.
Stroke, and this was not the same time.
Yeah,
Okay.
right now the disease is not in the active phase.
Okay, right. That is fine.
Yes. So, Justin Paul, sir, can we proceed with the panel discussion?
Please.
So here I would like to ask Dr. Vanitha about the effect of pregnancy and Takayasu and the Takayasu on pregnancy.
So, either Dr. Vanitha, Dr. Tara, please.
Actually,
you can discuss.
Takayasu itself doesn't have any progressive course on the disease, sir. So it doesn't alter the course of the disease. But the effect of Takayasu on the mother, there are so many complications pertaining to the disease itself. So because already patient will be on some immunosuppressant drugs, they are more prone for infections, and anemia and hypertensive patients. So they are more prone to have a preeclampsia also, almost 40 to 50% increased incidence of superimposed preeclampsia. And the pregnancy-induced physiological changes can aggravate the underlying cardiovascular risk also. And these patients are more prone to get abruption, and there is increased incidence of cesarean sections and some anesthetic complications also. And if there is a superimposed preeclampsia, the incidence of cardiac failure, aortic regurgitation, and the stroke, intracranial hemorrhage, and chances for getting convulsions is also very high. The patient is also having other aortic dilatation or the aneurysm. The chances for dissection of the aorta or the rupture is also increased, and chances for getting dilated cardiomyopathy in the peripartum period or the myocardial infarction is also high. So that is for on the maternal side. On the fetal side, there is an increased incidence of early abortion. Either it could be a spontaneous or it could be a therapeutic abortions. So therapeutic abortion if the patient is getting conception when the disease is under active phase. And if the patient is already on tetragenic drugs like for the disease control or the patient is getting some warfarin, so there is a need for the termination of pregnancy in the early part of that is first trimester. And later part of the pregnancy, the patient can develop intrauterine growth retardation or intrauterine fetal death. And there is chances for getting going for the preterm labor. And there is also chances for getting iatrogenic prematurity if the patient is developing superimposed preeclampsia. So overall, the pregnancy outcome will be maybe poor if the patient is getting conception during the active phase of the disease, or if she develops severe preeclampsia, or if the patient is having a multiple vessel infarction.
So I think there is a good point that there are two things here. One is how pregnancy affects the course of Takayasu arteritis, and the other one is how Takayasu arteritis affects the pregnancy. Now, coming to pregnancy affecting the course of Takayasu arteritis, it is a controversial. By and large, it is believed that pregnancy, most of the autoimmune diseases, what happens is the pregnancy will affect the course. In fact, they increase the flares. But the flares of Takayasu arteritis in pregnancy is sort of controversial. Many studies are reported, not many flares, but there are two studies that have shown that Takayasu may flare up during pregnancy, but by and large, the support is for that it is neutral. Now, coming to the effect of pregnancy, Takayasu on pregnancy, the effect may vary based on the severity of Takayasu. That is, I think, all the high effects in possible complications, maternal and fetal, were highlighted. But the severity of Takayasu, say Ishikawa's grading of severity, there are two things: Ishikawa classification and Ishikawa severity grading. So if you take a type 3 severity grading, these patients are more likely to have complications. Now, a third part of the question is an active Takayasu versus a burnt out Takayasu during pregnancy. Is there a difference? There is some literature data showing that disease activity during pregnancy has a greater effect on pregnancy outcomes than a disease inactivity. So it is always recommended during preconception counseling that if a patient is coming to us with Takayasu, it's always good to ensure that the disease activity is controlled before we advise them to go ahead with the pregnancy. Please go ahead with the review of literature, doctor.
Yes, sir. So there was a analysis of 505 pregnancies in 373 mothers with Takayasu arteritis, which was published in Seminars in Arthritis in 2020. They found that there are higher rates of pregnancy complications and poor pregnancy outcomes in Takayasu mothers compared to the normal mothers. Most common complication was hypertensive disorders, and other complications like cesarean section rate, prematurity, growth restriction, fetal loss were also high. And abdominal aortic involvement is associated with poor perinatal outcomes, and disease activity is an independent risk factor for poor pregnancy outcome, just as like Justin Paulser was saying. So here I would like to ask sir one question. How do you monitor disease activity and cardiovascular status in pregnancy, and are there any poor prognostic indicators that we have to be aware of?
Before I answer, I just would like to know, our seniors, Anith Saxena madam or Titus sir, Would you like to offer any inputs from based on your experience, Ayasa Raghav sir, Vanitha ma'am?
Sorry, Dr. Paul, I don't think I have anything to offer
Yes,
in this
Princy.
case till now.
So, okay, the question was, how do you monitor disease activity? Is that what? Can you go back on the slide?
Yes, sir.
Monitoring of disease activity. I think we discussed briefly about the ITAS score, as Dr. Malani highlighted that whatever has been going on in the past 3 months is what we are looking at. It has, I think, five or six headings. What is happening in the systemic level? What is happening at the abdominal level? What is happening at the genitourinary and pelvic levels? What is happening at the renal part? And what is happening in the CNS and the cardiovascular system? Now, anything that has developed new in the last 3 months, you give them the appropriate grading. So if a patient has developed a new onset BRUI or a new CVA, straight away they have a score of 2. So it becomes an active disease. So technically, to call it an inactive disease, most of it has to be negative. If it's less than 2, it means it has to be either 0 or 1. That is all. So if you have any of these things positive, by and large, it becomes a disease activity score. So there is another ULR score or a CARE score. NIH is the modification of the CARE score. Basically, it compared to the previous visit, any new constitutional symptoms or elevated biomarkers. So it is for us to importantly understand there is no specific diagnostic biomarker for Takayasu or no specific biomarker for disease activity. By and large, we use the common biomarkers of raised ER, ESR and CRP, though they can be elevated in other conditions, but the disease activity, any recent increase in the last couple of months is considered disease activity. But however, during pregnancy, the patient remains symptomatically status quo. And if there are no other findings, just elevated ESR or CRP alone, we may not modify our level of anti-immunosuppressive therapy. We'll just continue as it is. But we'll be definitely looking at the constitutional symptoms and features of vascular ischemia and new lesions on imaging. We may not go in for imaging straight away other than just Doppler imaging routinely, except when it is necessary during pregnancy. So if any of these scores are present, if the NIH score is more than or equal to 2, we call it active. The same way as we saw the ITAS score. ITAS score is Indian Takayasu Arteritis specific score. There is validated in more than 300 patients, Indian patients. So we can follow either of these things. So, well, the ULR consensus recommends that what exactly is a relapse, what is a remission. So remission is absence of all clinical signs and symptoms attributable to active disease and normalization of ESR and CRP and no evidence of new progressive vessel narrowing during pregnancy. Well, this is something that we always desire to have during preconception period so that we can say that go to the pregnancy, but you may not have always all these things. But then, if there is a good signs, or particularly if they have a good signs of disease activity, we have to discourage active pregnancy at that point of time, because we do have good, response to high dose steroids and immunosuppressants like azathioprine. We definitely does help to modify the disease. And once the disease control is achieved, we can ask the patient to go to the pregnancy. And these are some of the poor prognostic indicators. As I told you, the higher Ishikawa scale, basically a class 3 or class 2B, and presence of complications, retinopathy, hypertension, renal artery involvement, all these things are high prognostic indicators. In fact, if the patient has a significant renal artery improvement, the data shows that patient who have a balloon angioplasty or stenting to the renal artery before pregnancy, they have a better outcomes. So with the renal artery involvement, particularly the hypertensive complications are high and the fetal adverse outcomes are high. So these are some of the poor prognostic indicators of pregnancy.
Thank you, sir. Next question is also for you. So under what circumstances would you consider vascular interventions during pregnancy and also pre-pregnancy? And
Yeah.
how much time would you suggest, spacing or timing of pregnancy after vascular intervention?
Now, during pregnancy, generally we would like to avoid interventions unless there is some, life-threatening. Say if the patient develops a coronary complication, we will definitely have to intervene there at this point of time. Or if there's a critical limb-threatening ischemia, we may need to intervene during pregnancy. Well, I have not had experience of handling interventions during pregnancy in a patient with Takayasu arteritis. If anybody is there in the audience, you please send a message in the chat box. We would definitely like to get your inputs on that. And anybody from this high volume centers where you have the experience on handling this one, you please do not hesitate to open and share your inputs. And pre-pregnancy is very, very important that we all symptomatic complications are well managed. If there is a critical symptomatic subclavian artery stenosis, if it is well responded to, not responding to medical therapy, if the disease is quiescent, but there is burnt out disease, but still there is significant ischemia, we will need to intervene there. Renal artery stenosis, data shows that particularly, I think from Maulana Azad Medical College, they had Dr. Shakun Tyagi and Singh and team, they had presented a case series where they divided into it is only prospective data from India where they had looked at patients without renal artery stenosis, patient with renal artery stenosis, and patient with renal artery stenosis for which they have intervened. What they really found that was patients, what shall I say, who had a renal artery stenting before pregnancy, they had a good outcome. Dr. Kirti Priya from JIPMER, would you like to share the experience on aortic stenting in that patient, the refractory hypertension? You can unmute and speak if you're there.
Yes, sir. Good evening to all. So I'm currently doing a fellowship in obstetric medicine in JIPMER, sir. So we had a patient, she was 23-year-old primey. Actually, patient was a case of rheumatic heart disease also. She has undergone MVR in 2018. And post MVR, she was having moderate LV dysfunction also. And she was a known case of Takayasu. During that MVR, they had found she was having reduced arterial pulsations in the limbs, and that time she was diagnosed of Takayasu. So basically, at the time of diagnosis, she was having type 5 Takayasu arteritis with the entire aortic involvement with arch of dilatation of arch of aorta with AR. So patient was on immunosuppressants like MMF and then converted to azathioprine. So when she actually came to us at 11 weeks of gestation with severe hypertension. She initially came at around with the BP of around about 170, 100, 170, 110. So we are trying to do medical management with the patient. But by 24 till 20 weeks we were trying to do, but we almost added 5 antihypertensive agents for her with diuretics, and she was not responding to anything. Her systolic went up to 200, 220, her diastolic went up to 140. And we did a repeat imaging, and that was showing that same aortic stenosis. At the level of D7, there was a critical stenosis of about 4 mm only. And there was mild aneurysm, like aneurysmal dilatation also. And also her LV, her cardiovascular compromise was also happening. She was going into pulmonary edema. So so it looked like she was not keen on terminating her pregnancy. So at that point of time, we had to go ahead and do a stenting for her. But during the initial stenting, she developed intraoperative pulmonary edema, so they could not place a stent at that point of time because she became very sick. So, and then we resuscitated her, and then again at 26 weeks, we did a concurrent hysterotomy with stenting. So after stenting, initially she was not requiring much agents, but by 2 weeks or so, she again required 4 antihypertensives. And when she came to us, actually her disease was also active. So we think that the gross involvement of the aorta as well as the active disease was persisting, and that was not contributing to the improvement in the hemodynamics even after the stenting.
So you did
whether stenting
hysterotomy at
really helps in
26 weeks, is
pregnancies,
it?
Yes,
You did a
sir.
hysterotomy
Yes,
at
sir, we did.
26 weeks, and the baby?
Because patient was also worsening. Actually, baby was there for 1 week. After that, baby died of prematurity complications.
Okay, okay. What was the reason for going
So
to
there was
hysterotomy and
both a
not just
maternal
stenting alone?
indication.
Any inputs?
Sir,
Why did you
actually,
go for
during
this?
the second, yes, sir. During the second time when we attempted stenting, we had undergone, we did it under general anesthesia. And during the entire procedure, she was actually having full pulmonary condition. She was requiring 100% FiO2.
Okay,
And immediately
right,
after
right.
placement of stent, there was acute LV dysfunction which developed post the reduction of gradients.
Right.
So actually, intraoperatively, the patient was becoming bad. So we had to deliver the patient.
It was not a planned hysterotomy. It was emergency hysterotomy decided during the stent.
We were expecting complications. We had explained the patient that she might require hysterotomy intrapartum. And then we went ahead because she didn't improve intrapartum and she was worsening.
I think thank you very much, Dr. Kirti and Team Jipmer, for sharing your inputs. I'll get back to, I think so.
Thank you.
So these are some of the unusual situations where you'll be considering vascular interventions during pregnancy. Otherwise, it's always a pre-pregnancy preparation. It's never a cosmetic interventions in Takayasu. Just because there is a stenosis, we don't intervene at all. If the stenosis is causing symptoms and limiting symptoms, we definitely intervene and prepare the patient for a pregnancy. Dr. Malini, back to you.
Sir, yes. How much time would you say that patient has to be monitored before she can plan pregnancy if she underwent any intervention, say balloon dilatation or stenting?
Well, I
Before
think
she can plan a pregnancy after an intervention.
so. After balloon angioplasty or stenting, we will be keeping a dual antiplatelet therapy, and generally dual antiplatelet therapy is not considered a contraindication of pregnancy. We probably, it is just probably a 3 months or 6 months down the line. Once to ensure that things are fine. Maybe we should have called Dr. George Joseph from CMC Vellore, who has the largest volume of interventions in the world also on Takayasu pregnancy. Anybody else who has inputs on this particular area, how long we should have a waiting, please do not hesitate to give inputs or at least send a message in the chat box. I feel 3 to 6 months should be fine and ensure that disease is quiescent.
Can I come in, Dr. Paul?
Yeah, please.
So I think 3 to 6 months is probably okay for majority of the patients. I'm not really talking of pregnant women. I don't have much experience with that. But in other patients, I have seen that in some of them, the activity just goes on and on. So I think it is very important that we look at all the parameters, whatever we can, although I'm not very sure if we know that, what really indicates activity. ESR and CRP are not really very good indicators. I think there are patients who may have a normal ESR, normal CRP and still be active. So one is that PET scan is supposed to be very good to pick up activity, but then we don't want to subject them to PET scan again and again. So I guess 3 to 6 months, provided their ESR CRP has returned to normal, and the patient is of course asymptomatic, may be a good way of going about it. But really, I don't know the answer to this question also.
Thank you, madam. Thank you. Anita Saxena, madam, is a retired professor of pediatrics and is active pediatric cardiologist. So a teacher for almost most of the pediatric cardiologists in our nation. Thank you very much, madam, for being there. Dr. Malini, back to you.
Yes, sir. Thank you, Dr. Anita and Dr. Justin for the clarifications. So my next question would be to both the MFMs and the obstetrician. Management of pregnancy with Takayasu arteritis. How do you manage her in the antenatal period, and how do you determine the optimal timing and mode of delivery? Dr. Vanitha, if you can answer.
Yes, ma'am. So actually, the pregnancy should be planned when the disease is well under control. And during the first visit, when she missed her cycle, so when she is coming for the routine ANC checkup, certain things to be focused apart from the routine obstetric examination. So whether she is having taking the drug properly. So the compliance on the patient side is very, very important, particularly the immunosuppressant drugs, and whether she is not taking any teratogenic drugs, that has to be confirmed. And regarding the examination part, BP has to be checked in all the 4 limbs, and pulse should also be felt. They try to be felt in all the 4 limbs. And examination of the cardiovascular system, we have to look for the murmur over the chest and any bruit over the carotids. Then certain investigations, apart from the baseline investigation pertaining to the obstetric cases. So we have to look for the ESR, CRP, and renal function test, glucose tolerance test, and the routine complete blood urine for routine examination, and we have to rule out any underlying urinary infections. And if the BP is very high, if the Doppler is not done previously, we have to look for the renal artery Doppler and carotid artery Doppler also. And ECG, baseline echo should be done. Then during the 11 to 14 weeks, we have to look for the NT scan, and preeclampsia screening should be ordered between 13 to 14 weeks. And we have to get an early rheumatologist opinion. So this is for the first trimester period. And during the second trimester, so patient, apart from the routine iron and folic acid drugs, the drugs has to be titrated according to the rheumatologist opinion. And we have to educate the patient regarding the symptoms of relapse. And lower limb BP has to be monitored periodically with a larger size of the cuff, and antihypertensive drugs to be titrated according to the blood pressure. And serial ultrasound scanning should be done. And at 20 weeks of gestation, we have to order for an anomaly scan also. And repeat echo should be advised at 28 weeks. And in the second trimester, the AN visits should be ordered at once in every 2 weeks. And rheumatologist's opinion should be sought every once in 2 months, 1 to 2 months interval. And in the third trimester, the AN visit should be planned every once in 2 weeks up to 32 weeks, and thereafter every once in a week. Then we have to ask the patient to look for the fetal movements, because sudden intrauterine fetal death or intrauterine growth retardation more common. So we have to look for the serial ultrasound. If there is any features of IUGR is noted, we have to order for fetal Doppler also. And after 32 to 34 weeks, non-stress test should be done, and repeat echo should be ordered at term pregnancy, that is around 36 weeks of gestation. Then we have to plan, that is a birth plan should be done, where she is going to be get delivered, and team approach should be better to be obtained along with the cardiologist, rheumatologist, and the anaesthetist. So we have to plan the pregnancy in the absence of any other complication, that is the severe preeclampsia. If it is not there, then we can continue the pregnancy up to 37 to 38 weeks, and thereafter we have to go for a planned termination. If she is having any severe preeclampsia, then even earlier termination may be indicated. And then and there, the disease activity should be assessed with the CRP and ESR, and also with the rheumatologist opinion. And regarding the labor, so if the patient once she's entered into the labor pain, the first stage of labor, we have to monitor with the progress of labor should be monitored, and prophylactic antibiotics should be ordered. The stress dose of steroid, because the patient is on long-term steroids, so stress dose of steroid to be covered over the peripartum period for a period of up to 24 to 48 hours. And vaginal delivery, if it is planned, better to give an epidural. And cut short the second stage of labor, either with the instrument deliveries, that is, if necessary. If the patient is not able to put, then we have to go for a either vacuum or a forceps delivery. The patient is having any cardiovascular risk like aortic dilatation or the aortic aneurysm, it is better to go for elective cesarean section at 37 to 38 weeks. Then avoid fluid overload during the time of cesarean section also.
So,
Thank you,
so
Madam. I would like to.
planning an elective cesarean if the patient has a stage 2B or a stage 3 disease. Am I right?
Yes, sir. Yes, sir.
And I think probably in group 1 or group 2A also, if we don't have, what shall I say, a good control of BP, we are not able to get the BP in control, we may have to go for elective cesarean. In fact, the whole COMC, this masterclass started because we had a patient, one of our colleague from, I think, Calicut, he have a patient where they have a Takayasu, the pregnancy where all 4 limbs are involved. We are not sure what is the central aortic pressure. because the upper limb pulses are not felt and the lower limb pulses are feeble, and the recorded BP in the lower limb pulse is definitely not reflective of the central aortic pressure. So how do we measure BP in this patient? We do not know. Such patients, particularly if there is a retinopathic changes, it may be wiser to go ahead with the cesarean section, because the biggest in fact, if you look at all the series of, I think they have two series from PGH Chandigarh, one series from CMC Velu, one series from Fernandez Hospital, Hyderabad, one series from IPGMR Kolkata. All these are retrospective series, and one series from Maulana Azad Medical College. I found all these things, I think there were only 3 deaths. All these 3 deaths were related to hypertensive complications. So hypertensive complications, hypertensive CVA, and hypertensive heart failure. So it is extremely important that we should be able to manage the blood pressure. And if you are not able to understand what exactly is the blood pressure, it may be safer to go for elective cesarean section. This is just my opinion. I'm open to correction.
Okay.
Please go ahead.
Taramam, would you like to add anything?
Absolutely, I agree with Dr. Justin. One biggest problem is uncontrolled hypertension and mother requiring 3 antihypertensives, 4 antihypertensive drugs also we have seen. So when such scenario, it's safer to birth the mother after 34 also sometimes because of uncontrolled hypertension. And that's it, Malini. Continue. Thank you.
Yes, ma'am.
Can I interrupt you? Justin Paul?
Yeah, I'm with you. Sir, who's this?
Dr. Dasaru.
Sir, please. Dr. Tayasu Arteritis is a very senior cardiologist and teacher of most of the cardiologists here. Sir, please go ahead.
No, regarding measurement of blood pressure, when there is no pulses felt is to do an echo. If there is a mitral regurgitation, that the pressure difference between the LV and the LA is going to give you some idea about the central aortic pressure.
Exactly, sir. This patient didn't have a MR also. We were discussing in the cardio-obstetrics group as what sir is telling us, if echocardiography can detect a mitral regurgitation, we can measure the mitral regurgitation pressure gradient, it will give us a difference between LV minus left atrial pressure. And in the absence of aortic stenosis, LV pressure is exactly the aortic pressure, central aortic pressure.
Yeah.
We can assume the left atrial pressure, we can calculate the LV pressure, which means the aortic pressure is calculated. So the very important point, as the Yasagar Rao sir, my teacher, has pointed out, is that if we are not able to get the peripheral pressures, look for a mitral regurgitation in the echocardiography. You can indirectly estimate the central aortic pressure. But unfortunately, in this patient that we discussed, the patient does not have an echocardiography also. Mitral regurgitation also.
Okay. Either the patient has a mitral regurgitation or even aortic regurgitation also. We can measure the what we call mean aortic pressure.
Yes, sir.
So probably when there is no pulses felt in the periphery, ask the echocardiographer to do it. If there is an MR or AR, we can still measure it, or at least have an indirect estimate of the severity of the central aortic pressure.
Yes, sir.
Yeah. Can I ask you one more question, Justin?
Yes, sir. Please, sir.
Usually during pregnancy, there are vascular changes occur within the major blood vessels, including aorta.
Yes,
has there been any systematic study about what happens to aortic sizes and these aneurysmal dilated portions of the vessels during pregnancy in aortoarteritis?
Sir, I don't know that any study looked at that. I looked at all the Indian series, and there was one large Chinese series of 110 patients. There's a French series. So, but they all looked at the outcome, maternal cardiac outcome, maternal obstetric outcome. There was hardly anything in particular about, there was no cases of aortic rupture or significant aortic dilatations. Vascular aneurysms were noted for the first time once or twice during pregnancy, but then they were not leading to any major complications. No cases of aortic rupture or dissection have been reported.
Okay. Thank you.
Thank you, sir.
So my next question is to Dr. Manokanth. He is the obstetric anesthetist at Fernandez Hospitals regarding the hemodynamic monitoring during labor or during cesarean, and how do you manage the BP fluctuations?
Yeah, so a primary objective is to maintain or manage the blood pressure and then also organ perfusion. And any of these Takayasu patients, the other thing is to assess the effect of the hypertension on mainly cardiac and renal functions and any presence of pulmonary artery hypertension. So broadly, these are the things that will affect our management. For hemodynamic monitoring, like in a patient where we are unable to do non-invasive, NIBP, you can go for central artery cannulation, mostly femoral artery cannulation, and measure IBP or invasive blood pressure. So that's one way of measuring, but obviously it can be done in a perioperative situation, but not as a routine. So if the patient is for cesarean section, we can place a cannula in femoral artery and then measure the blood pressure. And we can use NTG infusion in the perioperative scenario to maintain the blood pressure, and you can use beta blockers, and you have various vasodilators to manage the blood pressure. So during anesthesia, you neither want the pressure to shoot up suddenly nor to fall below a certain level, because it can both ways it can be harmful. So for monitoring, it is if you are unable to get an NIBP measurement, cannulate the femoral artery. It should be fairly straightforward to measure the blood pressure. Anesthesia management per se, then obviously, like Dr. Vanitha was mentioning, if we are going for normal delivery, if we are able to measure the blood pressure and if you have a grip of what the pressures are, then you can put an epidural and allow her for vaginal delivery. If you are taking up for cesarean section, again, a low dose combined spinal epidural is the anesthetic of choice over general anesthesia. By low dose, again, I mean the bupivacaine heavy that we use for spinal anesthesia. Keep the dose around 5 to 6 milligrams so that there is no drastic fall in blood pressure, and then top up the epidural to achieve the desired level of anesthesia block slowly. Again, any hypotension can be corrected by a phenylephrine infusion and with the spinal anesthesia. For general anesthesia, if there is only hemodynamic instability, if there is any coagulopathy, if for some reason you're not able to put an epidural or do a regional, then only general anesthesia. There, again, at intubation, you'll have a spike in blood pressure, so that can be controlled by a small bolus of NTG or esmolol. You should use opioids. You should not avoid opioid at induction in such patients to cut down any spike in pressures.
Yeah.
Thank you, Dr. Manokanth. I have one more question for you. Very, very rough question only. Over a period of, I think, their experience at Fernandez, how many patients with the Takayasu you would have supported the obstetric management, number one? And was there any patient where you had to put a femoral artery cannula and take it to the central aorta to monitor the aortic pressure?
Patients, I think we did fairly large number of Takayasu arteritis, but most of the times we are able to get either NIBP on the legs or on one of the arms. This is the usual case. Very rare that you are not able to get a good NIBP measurement in any of the limbs. Then if we are able to feel a good pulse in the limbs, then we'll go for a radial artery cannula. But again, I don't remember putting a femoral artery cannula for blood pressure measurement, honestly. Like generally, if you have a better pulse in right hand or left hand, then we'll go for artery cannulation of that hand. But
supposing, this is the case that we discussed. My friend Rajesh from Calicut, and I think Dr. Jyoti is also here. So if that patient, you are the anaesthetist, and the patient's, the aorta is not discontinuous, it is continuous, but then femoral artery pulse is definitely not, very feeble, and the radial artery pulses are not felt. So there are significant hypertensive retinopathic changes. It means that central aortic pressure probably is high. So you are taking the patient for anesthesia. Would you like to put a femoral artery line?
Yes, definitely. We can use ultrasound and put the radial artery cannula and measure the IBP. And
The
then
radial artery cannula may not give you the central aortic pressure unless you take the
no,
cannula
femoral,
all the
sorry,
way up to the central aorta.
femoral artery cannula under ultrasound, and then measure the blood pressure and do a regional anesthesia.
Thanks, Dr. Manokanth. Thank you. Dr. Malini, back to you.
Yes. So coming back to our case, so she was admitted at 32 plus 5 weeks with threatened preterm labor. She was steroid covered, but since she progressed in labor in view of 2 previous cesarean sections, an emergency preterm cesarean section was done and a 2.78 kg boy baby was birthed. And we have given stress dose of steroids during her intrapartum and immediate postpartum period. So post-operative period, her BPs were high, which we were measuring in the lower limbs. And she was started on labetalol 200 mg hourly and titrated as per her BP monitorings. We gave her postpartum thromboprophylaxis, continued her on azathioprine, prednisolone, and breastfeeding was initiated. And she was discharged on post-operative day 3. So coming to the postpartum monitoring of women with the Takayasu arteritis. So we have to monitor them closely in the ICU and close vigilance for precipitation of any cardiac complications and look for signs and symptoms of relapse. So we have to counsel regarding the compliance of medications. They may be having a lot of questions and doubts regarding the safety of medication in lactation and the effect on the baby. We have to reassure them that the corticosteroids, azathioprine, tacrolimus, and cyclosporin are safe during breastfeeding, and she can exclusively breastfeed the baby whenever she is on these medications. And close follow-up with the multidisciplinary team that she is following with, be it a rheumatologist, be it a cardiologist, she has to do it even postpartum. And earlier, if she has any new symptoms, she has to visit them immediately, because we have to be watchful for the relapse. And for the contraception, long-acting reversible contraception is better in the form of levonorgestrel intrauterine systems or a progesterone implant. And long-term follow-up and monitoring and progression of the disease is very important for her lifelong monitoring and progression of the disease. Coming to pre-pregnancy counseling, we need to have a multidisciplinary team approach, assess disease activity, both based on her symptoms, physical examination, labs, as well as imaging, and evaluation of other organ systems, whether retina is involved, whether cardiac is involved, or renal arteries are involved, and explain about the side effects of the disease, effects of the disease on pregnancy, pregnancy on the disease, effects of the medication, what she can take, and if she is planning pregnancy, change over to pregnancy safe medications. And when she conceives in remission, we have a very good favorable perinatal outcome, that is 80 to 85% successful outcomes we have seen. And adjustment of pregnancy safe drugs during pregnancy and during lactation also has to be discussed. Use of endoprosthesis or surgical collection of occlusive or stenotic lesions pre-pregnancy, as we were discussing, and delayed at least by 6 months after the procedure. And if we are asking her to avoid pregnancy, discuss contraception, screen and treat comorbidities, anemia, hypertension, diabetes, folic acid supplementation in the preconception period, early booking, and again, stress the importance of close monitoring with the multidisciplinary team. Tara ma'am, would you like to add anything to this preconception counseling?
Not really, Malini. I think the first and the foremost is a close network with the cardiologist and the rheumatologist is essential for every mother who comes to your doors with a Takayasu arteritis. And the staging, disease activity. Our mother is this lady who birthed with us is a classic example of late booking. Never she could come, in the early pregnancy. So there are some, inherent problems for these people who have chronic diseases, and we should form a close network with the teams and work together, like how we do cardio-obstetrics. I think we have to have a rheumatology, obstetricians, everybody, all of us together can help the woman. And this particular lady, if she would have come in the early pregnancy, we could have done an antiphospholipid antibody screening for her because of the previous outcome, which showed a maternal vascular malperfusion, as well as the association of the connective tissue disorders with the Apler syndrome. Thank you.
Thank you, ma'am. And this is just a slide showing the various drugs that we usually use in Takayasu arteritis and their safety profile during pregnancy as well as lactation. And this is our own the chart that we follow whenever a patient with Takayasu comes. We have this form attached to their file showing the type of the disease, is there any progression activity, and also patient information on what she should, on signs and symptoms that she should be watchful for. Thank you, sir.
Thank you. So,
Justin, can I make a comment?
please, sir. There is Dr. Thomas Titus, my professor, under whom I learned in Sri Chitratharnal Institute, Trivandrum, between 96 to 98. Sir, thank you for joining. Please make your comment.
I think very, very enlightening talk. I think I had two comments to make. I think one, of course, the case from Jikmar. The patient had an MVR for mitral regurgitation, and there was some LV dysfunction. So we do not know how much of the LV dysfunction is contributed to, because the arteritis can produce a cardiomyopathy-like picture. So it may be rheumatic mitral regurgitation, may be intervened a little late, which had the LV dysfunction, or it may be a part of the arteritis, the residual LV dysfunction that the patient had. That is number one. And second thing, I was about to actually ask you about the incidence of the middle aortic syndrome, where you have thoracic abdominal aortic involvement, significant stenosis. I think that is the similar case, I think, which I think has been stented at the Pondicherry group. And I think the stenting, I think, of this abdominal aorta is actually quite difficult because of the severely fibrotic stenosis that these patients have, unlike pliable vessels. So I think they are bound to have residual stenosis. I think this patient has also, you said, had residual stenosis of the abdominal aorta post-stenting. So I think because the tissue in the burnt out stage is quite tough and fibrous, so it may not completely yield like in a pliable vessel. So which made this patient have a residual stenosis. That's what I think you made. And I think it's important that because this middle aortic syndrome will add to the uterine and the abdominal ischemia, which can actually complicate the pregnancy. So I think if appropriate indication is there, I think it should be addressed even during pregnancy. Thank you.
Thank you,
sir. Thank you.
Any questions in the chat box? Anything to be added?
Manokanth already answered one question, and the other is risk for offspring to have Takayasu. Not really. A few genes have been identified, but there is not like a direct risk for the offspring.
Is there any risk of any fetal malformations? We know that azothioprine is relatively safe in pregnancy. Any fetal malformations in the offsprings who have been treated, delivered during the disease of arteritis disease process? Are you aware?
Actually, not really, sir. Most of these mothers whom we birthed were on azathioprine as well as the steroids, and both are relatively safe because the maximum registry of that azathioprine came from the lupus treatment of post-renal transplants and lupus pregnancies. So there were no anomalies in the most of the studies. Actually, also the studies which we have mentioned on these drugs, safety was established.
Any comments from the audience? Anything else before we close? Any comments from the audience? Anybody would like to say something or anything in the chat box? So if not, what we really understood today is that, Takayasu arteritis is a multi-system disease. And basically, it's a vascular disease. It's involving multiple systems. If we really need multiple system coordination, we need a good coordination between the obstetricians, cardiologists, rheumatologists, obstetric anesthetists, and if necessary, neurologists, depending on the involvement of the system. Well-planned coordination necessary for management of the patients. The preconception counseling, identifying the patient, because by and large, we identify the patients very early. So we need to prepare this young women of childbearing age for conception by preparing them, by modifying the disease activity and ensuring that any complications are dealt with by appropriate surgical or endovascular corrections. And we should be familiar with the disease activity scale. We discussed about 3 different disease activity scales and what is really happening to the disease activity. And once we ensure the patient is pregnant, the team has to be involved, and we have to be very carefully training the patient to watch for any fetal, because more severe is the disease, more likely is the adverse maternal and the fetal outcome. They should be trained to monitor early signs of fetal hyperperfusion or fetal issues, and we have to identify which patients are those who really need to choose for elective cesarean section, where we probably will not be able to give a trial labor. So with that, I think my sincere thanks to all the audience for having been there from the beginning, and my particular thanks to team Fernandez Hospital for having agreed to make this presentation in the last moment and for having made it well as well. It was not just 2-3 days preparation. It was a very good preparation. A lot of questions actually from the original presentation was shared by the Fernandez Hospital team. I realized that we'll be having a very fruitful discussion for about 2 hours. But considering the limitation of time available, we had to choose the more important points for discussion. And thank you, Team Fernandez, for always being there for Cardio-Obstetrics. And my sincere thanks to the audience and sincere thanks to the senior professors who joined, Anita ma'am, and Dr. Dayasagar Rao, Titus sir, and all others, my colleagues and my friends and my students and my juniors, and the team, Dr. Annie, for being there, and the team of our Cardiovascular Research Unit team. Thank you so much. Thank you, everyone. Thank you, everyone.
Thank you, Dr. Justin, and thank you, everyone, for this wonderful opportunity. Thank you, Malini and Stary.
And that was Dr. Tara, who was the one who immediately said that our team will do, and she immediately enabled her team to do. Thank you, Professor Tara. That it was a great job you have done. Thank you so much.
Thank you. Thank you so much.